My patient coded 3 times at the beginning of my shift. And I need you guys to listen to this story and tell me who is at fault. Hi guys, at shift change when I got reports from the day shift nurse told me that this patient was non-compliant, didn't want vital signs being taken on them, didn't want certain procedures to be done for them, didn't want PTOT, refused some medications, didn't want, like I said, vital signs, didn't want to be cleaned. And this patient came to the floor or to the hospital for narcotic withdrawal as well as alcohol withdrawal. Now, during shift change, patient's vital signs looked fine, at least for the blood pressure that the patient allowed or agreed that we should take it. The patient refused for the oxygen monitor or probe to be hooked to their finger, and so we had no idea what this patient's oxygen was looking like. The last oxygen that was taken for this patient was timed or was documented at 3:30 p.m. in the afternoon. What happened? During shift change, the patient kept insisting that they wanted their pain medicine. Now, we kind of understood that this patient was in pain. This patient also came in with some wounds that we could understand that this patient was going to be in pain. And now the patient's fentanyl was due to be administered. But for some reason, during shift change or when I was talking to the day shift nurse during handoff, the patient kept interrupting our conversation, just wanting their pain medicine no matter what we were saying. And when the nurse had already finished giving their shift report and they had left, she also mentioned that this patient was threatening to leave AMA if the patient did not get their pain medicine. Now, one thing you have to understand about pain medicine is that it messes up with your blood pressure, it messes up with causing constipation in the patient, it can mess up with the heart rate, and it can also mess up with the patient's oxygenation and also the patient's consciousness in terms of making them more sedated. And in that case, they will have to give them Narcan to reverse that narcotic or the pain medicine that was given. Pain medicine is always that kind of medication that is very, very timed, and I, for one, I always like to give the medication when it is due. I do understand that sometimes we have that window of 1 hour to give pain medicine or, to give certain medications, pain medicine inclusive, but I always like to give narcotics especially or pain medicine when they are due. If it says 4 hours, I like to give it 4 hours on the dot. Now, this patient was that patient who wasn't keeping tabs with when they received their previous pain medicine, and so they just kept calling and calling for pain medicine. Now, this was already frustrating on the staff, and the patient was now becoming aggressive and saying that they wanted to leave AMA because, according to them, we were not treating their pain appropriately. Now, at shift change, the patient also mentioned that, hey, if their pain medicine wasn't given, they were going to call family and family was going to come pick them up, and they didn't care what was going to happen to them. They were going to leave AME. After shift change, or after the nurse had given the report, I walked out to look at when the next pain medicine was due. So during shift change, the day shift nurse also mentioned to me that the patient had bilateral lower extremity wounds and they wanted to do an MRI. Now, it was up to me to go ahead and fill the MRI form. So I said, okay, let me come into the patient's room and, fill the form, ask those questions, and then, try to know the patient's pain level. Obviously, I know the patient was going to say 10, but those are certain questions that we always have to ask. Now, by the time I was done looking at the computer and I'm getting ready to walk into the patient's room, the telemonitor tech calls me and says that this patient has gone into a second-degree block. I look across from the glass in the patient's room and I saw that the patient's heart rate was dropping. So from a 67, it went to a 38. I turn and I tell the charge nurse, hey, this patient's heart rate is dropping, and the telemonitor just called to say that the patient just went into a second-degree heart block. By the time I was even gowning up, because the patient was also on isolation, by the time I was gowning up to go into the patient's room, guess what happened? The patient went heart rate dropped into the 20s, went to 15, and then the charge nurse shouted or screamed that I should hurry up and go get the crash cart. By the time I got to the patient's door, to gown up and get into the to the patient's room, and do everything with regards to the crash card, guess what? The patient went into asystole and we had to call a code blue. Luckily, before we even called that code blue, I had already called a react because the patient's heart rate was dropping very fast immediately when the telemonitor tech called. So after the react, I just went ahead and I called the code blue, and the react team or the code blue team, they were already walking in, and so when they heard the code blue overhead, they just ran into the room and we did all that we could do to save the patient. Something you should know about this patient was refusing for their oxygen to be checked. This patient was refusing labs. And so during the code blue, we did everything that we had to do. The patient was kind of like a very difficult to intubate, but we kind of succeeded. We stabilized the patient. Now, on the step-down floor, we don't handle or deal with patients who are intubated. So they were waiting for an available nurse who was going to receive this patient, meaning that ICU nurses usually have just 2 patients, and so they were all booked on max to 2 patients. So they were waiting for one patient to be downgraded, and then the available nurse could take this patient. So whilst they were waiting and this patient had been intubated, guess what? Within like 20 minutes, they had to call another code blue again, because whilst the patient was intubated, the respiratory therapist was still at the bedside holding, just making sure that the patient's O2 saturations were okay. So whilst they were there, 20 minutes later on, they had to call another code blue because the patient's O2 sats were dropping. Now the team came in again. They had to resuscitate the patient. They had to do a whole CPR again, and then it was at that point that the ICU nurse practitioner was like, okay, what were the patient's most recent labs? Now we went and we had to go check, and the patient's most recent labs was 2 days ago, just because the patient had been refusing their labs. And guess what we found during that the lab check? The patient's potassium was a 5.3, and then now they had to treat the patient as if it was a hyperkalemia situation. We had to rush to go get insulin, protocol that involves hyperkalemia. And then whilst that was happening, the patient's blood pressure was also dropping. And so during that second code blue, they had to get an arterial line for this patient, and they had to start infusing Levofed to kind of stabilize the patient's blood pressure. Now everything was done, and then the whole team had left again. Respiratory therapist was still there, because on the step-down floor, when the patient is intubated, the respiratory therapist and maybe the charge nurse for the ICU has to stay in the room until the patient is transferred to the ICU, because they know how to monitor, or they know how to manipulate the oxygen numbers on the machine, or on however they feel like the patient's oxygenation or O2 saturations look like. So while the respiratory therapists were still at the patient's bedside, monitoring everything, like 30 minutes later, I heard another code blue. Mind you, in the patient's room, yes, sometimes we can go to the nurse's station, we pick up the phone and we have to call a code blue, but there's also a button in the patient's room, or in every patient's room, where you can just pull and then it automatically signals a code blue. Now, I heard the third code blue and I'm like, okay, what is going on? The same thing all over again. The patient's blood pressures were dropping, the patient's O2 saturations were dropping. They had to do another round of CPR. It was just so chaotic in the room. Everybody had to run and come back. They had to do the same thing all over again. And then when things were situated, or when things had calmed down, it was during the third code blue that the nurse practitioner was like, I know the patient had been refusing to put on the pulse oximetry, but she wonders what the patient's O2 was during the first code blue. It was then that we realized that the patient's O2 last was at 3:30, and she made a comment saying that someone had to be written up. And I'm like, patient is refusing or non-compliant with vital signs. How is that the nurse's fault? How is that the CNA's fault? How is that the nursing staff's fault? I do understand that maybe they should have escalated it to kind of like hook the patient onto restraints, because it was necessary that they take the patient's vital signs, especially when patients are brought on the step-down unit. But again, the patient was feisty, the patient was refusing everything, and so we just kind of like let the patient be, at least for the day day shift, because all of this happened at the beginning of my shift. It was just 7 o'clock when I was actually wanting to walk into the patient's room to ask, to kind of fill this MRI form and to also ask them their pain score. When the patient became stabilized after the third code blue and the patient had to be moved to the ICU, when the patient hit the ICU floor, guess what happened? The patient had their fourth code blue. At this point, the patient's heart rate had already dropped so low that there was no way that the patient could stay on the ICU without some surgical intervention being done. It was at this point that the patient was rushed to the heart hospital for a pacemaker placement. Remember, the patient's heart rate was dropping, and so the patient needed a pacemaker to kind of stabilize the heart rate. During the first code blue, ICU nurse practitioner went ahead and called the patient's brother and cousin. So they were already on their way, because mind you, this patient was already thinking of leaving AME. So he had already called his family to come pick him up. And so when they called the family or the brother during the code blue, they said, okay, they were already on their way, because he called that he wanted them to come pick him up. Now, when they got there, during the code blue, usually there's going to be someone who holds family aside, someone who is explaining to them what is happening. And so they had to, after the third code blue, walk them to the ICU, got them situated, and then when the fourth code blue happened in the ICU, they had to take the patient and the family to the heart hospital for the pacemaker placement. Imagine all of this happening at the beginning of your shift. Now, from after when I had taken reports till about 1 a.m., I had done nothing for my other 3 patients. Nothing. Because while this patient is in this situation, you have to still attend to this patient. At least make sure that you are documenting what happened before you call the code blue, how everything went down, look at the vital signs, make sure that you're covering yourself, because if someone had already mentioned that, hey, patient's vital signs were not fully documented before the code blue, then it was up to me to know that, hey, I needed to cover myself and, document or write a nurse's note to kind of describe what happened right up till the first code blue was called. Looking back at what happened that night, after that messy code blue, 3 code blues on my floor, now they had to clean that room, and then I had to now take the 4th patient. Guess what? When that 4th patient came, that 4th patient was even very hectic. The patient was confused. The patient was also non-compliant. The patient did not want to be touched. The patient did not want any medical intervention being done on them. The next day, it turned out that this patient had to have an amputation, but the patient was refusing the amputation. The patient was kind of being rude. The patient was just speaking to us using some words which I don't want to say here, but it was just making my shift very, very tiring. Now, after narrating all that happened from 7 p.m. to 1 p.m. of this patient's 3 code blues on the step-down unit and 1 code blue on the ICU before being whisked to the heart hospital for the pacemaker placement, I think that 2 things could have been done to prevent this situation from happening. One, from the patient's point of view, I feel like if the patient had been compliant in us taking their labs, we could have been able to catch their high potassium. If the patient had been compliant in us, monitoring or taking their vital signs, it would have been easy for us to catch their oxygen. And also the fact that the patient was being grumpy and also just wanting only their pain medicine and nothing else. I feel like if the patient was being open to care, I feel like if the patient was letting us to take care of them, probably we would have evaded this scenario. Another thing that would have probably evaded the 4th code blue in the ICU was the staffing issue. I feel like if there was an ICU nurse who was available to take this patient, probably the patient would have been getting their ICU care already, which maybe would have evaded the 4th code blue, or probably the 2nd and the 3rd code blue. But guess what? This patient still had to be kept on the step-down unit until they figured out which ICU nurse was available to take this patient. And so if the patient had hit the ICU floor, I feel like it would have evaded that 2nd code blue and the 3rd code blue on my floor. After hearing the story so far, what do you think would have been done to have evaded the chain of events that happened for this patient? What do you think could have been done to maybe prevent such situations from happening in the future. I want to hear your comments. I want to hear what you guys have to say. Let us chit chat. Staffing is still a very big problem in most hospitals, and until this situation or until this issue is being handled and handled for good, I feel like patient care will always be lagging behind in terms of the way we care for the patient, in terms of our promptness and timeliness in doing certain things for the patient. I can tell you that there have been so many times that I have come to the floor. We don't even have a tech. We don't have a full charge nurse because the charge nurse has their own patient load. And these are situations wherein if the charge nurse was fully available for us, sometimes it makes the shift go smoothly. It makes us to have that extra hand in case we need something we need to do for the patient. Staffing will always be a very big issue in terms of patient care. If this can be settled, if this can be sorted out, I feel like there's so many things that will be evaded in terms of the kind of care that we give to our patients. Let me know what your take is on this scenario and what you thought would have been done and what you think you should have done and what you think you could have proposed to your hospital to evade such situations in the near future. If this is your first time stopping on my channel, please do consider liking, sharing and subscribing. And from me to you, I'll see you guys in my next one. Stay blessed and I'll catch you later. Bye guys.